I think what has evolved over the last few decades is more and more children's hospitals, CHOP, Boston Children's, Johns Hopkins, Children's National Medical Center in Washington, D.C., started to bring together multidisciplinary teams.
So when you talk about these clinical pathways, how crucial are these for attorneys to understand in medical malpractice cases?
The pathways at many of these children's hospitals, believe it or not, are easily accessible, not only to the physicians and nurses caring for the patient, but they are out there on the web.
Hello and welcome to a brand new episode of On the Stand with Ashish Arun, where we explore the law, practice and business of expert witness testimony. I'm your host Ashish. I'm the founder of Xlitum, where we're building an AI-enabled expert witness platform to help attorneys find, retain and research expert witnesses. Today, we have an exceptional guest who bridges the gap between pediatric emergency medicine and the courtroom. Dr. Robert Belfer brings over 30 years of experience caring for ill and injured children in tertiary care pediatric emergency departments. He's a board-certified pediatric emergency medicine physician. He earned his BS from the Wharton School and his MD from the Perelman School of Medicine at the University of Pennsylvania in 1987. He completed his pediatric residency and fellowship in pediatric emergency medicine at Children's National Medical Center in Washington, D.C. Beyond his clinical practice, Dr. Belfer has established himself as a thought leader and educator in pediatric emergency medicine. He is the host of CHOP's Pediatric Emergency Medicine podcast, where he has produced over 30 episodes interviewing national and international leaders on critical topics from sepsis and appendicitis to febrile infants and abusive head trauma. The podcast has garnered over 50,000 downloads worldwide and serves as continuing medical education for physicians. He's a frequent speaker on critical topics including sepsis, pediatric resuscitation, febrile infants and appendicitis, conditions that frequently become the subject of litigation. His expertise areas directly align with the most common pediatric malpractice claim. But what brings us together today is Dr. Belfer's extensive experience as an expert witness. He's been retained as a lead expert in over 75 cases, helping attorneys establish standard of care compliance and identify breaches in pediatric emergency medicine cases. His approach integrates clinical experience, evidence-based protocols, CHOP's clinical pathways, and current scientific literature to form objective medical opinions. So let's dive into this fascinating intersection of pediatric emergency medicine, clinical protocols, and legal expertise. Dr. Belfer, welcome to the show.
Thank you, Ashish. It's a pleasure to join you.
The pleasure is all mine. So you've dedicated over 3 decades to pediatric emergency medicine. So how has the evolution from individual physician judgment to protocol-driven care changed both clinical practice and medical legal evaluations?
So, Ashish, we could start with clinical practice. I remember early on in my training, we looked at each case individually. We talked about the febrile infant over and over again. What should we do for this child? What should we do for that child? And I think what has evolved over the last few decades is more and more children's hospitals, CHOP, Boston Children's, Johns Hopkins, Children's National Medical Center in Washington, D.C., started to bring together multidisciplinary teams. So not just emergency medicine doctors, but emergency medicine doctors, pediatricians, subspecialists. They took a topic, and let's focus on infant fever, okay? And over time, with all the physicians' input, they developed, edited, rewrote constantly the febrile infant guidelines or protocols. I think this helps the patient greatly. In other words, before the development of these protocols, there were many different approaches to the febrile infant. And the professionals who are part of the pathway development have used evidence-based medicine primarily, in addition to clinical gestalt, but it really focuses on evidence-based medicine, peer-reviewed journals, studies that have been validated over and over again using large sample sizes, in this case of febrile infants, to create a protocol which best serves the patient. And it also best serves the clinician, tells them, depending on the age of the patient, depending on the physical exam findings, what laboratory studies to obtain. Based on the results of those laboratory studies, what antibiotics, if needed, are necessary, and disposition, whether it is safe to admit the patient or discharge the patient. So I think we've come a long way, whether you're seen in the northern United States, the Midwest, the West Coast, and you are a febrile infant. Most tertiary care children's hospitals are very protocol driven, and the goal is that you would get the same approach, the same lab evaluation, the same antibiotics, whether you're seen at any one of these children's hospitals. And the approach, and let me emphasize, Ashish, is evidence-based. It's not just a group of doctors saying back 20, 30 years ago, what do you think we should do for this patient or that patient? This is all based on the evidence. And that's sort of, in a nutshell, I know we'll dive a little bit deeper, that I think is the genesis and the utility and value of protocol development. Now, the second part of your question, how does this translate to the legal profession? And I think it is not a one-size-fits-all idea. Pathways or protocols, we like to say, we throw out this term, the 80-20 rule in medicine, and I think pathways fit the same thing. In other words, 80% of febrile infants, let's say, you can follow that protocol to a T and things will work out fine. But not every patient, due to their comorbid conditions, their underlying diseases, the laboratory test results, they don't fit that pathway to a T. So I think there comes into play what I would call a hybrid or a combination of protocol-driven care or pathway-driven care, and also physician gestalt, meaning how do you interpret the physical exam of the child? How do you interpret the laboratory tests and use protocols, but also what I would call a little slow thinking. And again, there's many books written about fast thinking and slow thinking. I think we could look at pathways as fast thinking. Plug the child's age into the pathway, plug the child's exam, laboratory tests into the pathway, it'll tell you what to do. But I think in all these children, whether or not we use the pathway solely, we need to take a step back and use what I would call slow thinking. Hey, does this patient truly fit the pathway? Is something out of whack here that really is not exactly what the protocol states? Then you need to stop, look at the patient in front of you, start to slow think and determine, is this the best approach? Can I just, like AI does, can I just look at the pathway and practice pathway medicine? Or do I need to take a step back, maybe even look at some of the evidence that was used to derive the pathway and say, you know, my patient doesn't necessarily fit this to a T. I think I'm going to deviate slightly. And that, in my opinion, from a medical legal issue, is still standard of care. I guess there's many ways to skin a cat, and not all of them should be pathway driven.
So when you talk about these clinical pathways, how crucial are these for attorneys to understand in medical malpractice cases?
Sure. The pathways at many of these children's hospitals, believe it or not, are easily accessible, not only to the physicians and nurses caring for the patient, but they are out there on the web. So you could click on Boston Children's website and look at many of the pathways. Many children's hospitals, like I said, the pathways are out there for doctors, nurses, literally anyone, parents, and lawyers to visualize. I think ideally the pathways are published and disseminated to care for the patient. I don't believe any of these centers have published these pathways for lawyers to have their eyes on. But if you want to disseminate them to clinicians, there's really no way except by putting some kind of hardwall up to not allow lawyers to access them. And I think an issue with that, Ashish, is that there is some interpretation of the pathways. They dive deep into laboratory test results, what testing should be obtained. And at times in the pathway, there's some room for interpretation of how the patient is clinically and what those lab tests are. Let me give you an example. They may say if the patient is ill-appearing, you go down this pathway. Well, I think a clinician, we train dozens of years to recognize an ill-appearing child. A lawyer, on the other hand, is looking at the medical record, or having their expert look at the medical record to try to pull out, are they ill appearing based on the medical record versus the actual clinician who took care of that patient in real time is applying their bedside acumen to the pathway. So I think while the pathways were not put out for lawyers' eyes and ears, today in the medical legal world we live in, with easy access, like I said, to these pathways, lawyers have access to the pathway, and they or their experts will try to retrospectively look through the medical record and practice, I guess, what I would call pathway medicine and see if there's any deviation. And I emphasize in the first question, this 80-20 rule, not every patient fits a neat pathway. The majority of them do. And I guess I would argue also, Ashish, the cases that end up in the courtroom or lawsuits filed, many of those are in the 20% group of infant fever, appendicitis, and sepsis.
Today's episode of On the Stand is brought to you by Xlightum, the AI-powered platform where attorneys find expert witnesses and experts grow their practice. Every week, hundreds of new experts join Xlightum, giving attorneys instant access to qualified witnesses without any finder's fee or markups. Need someone else to handle the vetting? Our concierge service does it all. You only pay when you retain an expert we present. So whether you are searching yourself or letting us do the heavy lifting, Xlightum makes expert discovery fast and smarter. Visit Xlightum, that's exlitem.com, to find your next expert witness today. When evaluating a case, how do you determine, and I know that each case is different depending on the facts and where you are, but how do you determine whether a deviation from a clinical pathway or protocol, is that a breach of standard of care versus it's an acceptable clinical judgment?
Yeah, I think that's an excellent question, Ashish. And I can answer that by saying not every tertiary care children's hospital rubber stamps the other's clinical pathway. So there are some variations among the protocols. By and large, they are pretty straightforward. But what I mean by that is certain laboratory tests and results of those tests may appear in one pathway, and in another children's hospital pathway, there may be some deviation. So they're interpreting the same literature, they're getting they're getting similar experts at each of these children's hospitals, but the pathways are not, there is no one universal pathway, I guess is what I'm saying. And I think that is the flaw, I guess, in relying just on a clinical pathway. I think in the cases that we're discussing, specifically, we're now talking about the infant fever, there are some variations, okay? And we also need to emphasize when that care took place, because I would argue, Ashish, every few months, every 6 months to a year, there are updated clinical literature, and the experts at these hospitals will look at that literature and then over time may alter, amend, update that pathway. So I think when we're looking specifically at infant fever, we need to look to see, was this case in the fall of 2022 or was it in the winter of 2024? Because over that time period, Ashish, many infant fever protocols and pathways have been updated and amended based on the availability of newer and better laboratory studies, and also based on input from the experts who create these pathways.
So, Dr. Belfer, you frequently speak on sepsis, and that's something we found in our research. So, and this is a condition with high mortality if not caught early. So, walk us through how sepsis protocols have evolved and what attorneys should know about the golden hour in sepsis cases.
Yeah, as you mentioned, Ashish, I have published the podcast about sepsis. I speak nationally on the topic, and pediatric sepsis is a unique disease. What I mean by that, it is not common, okay? Not as common as our adult colleagues who take care of elderly, ill, sick patients with pediatric sepsis. Pediatric sepsis is rare. And I want to emphasize it's even rarer for an otherwise healthy child to develop sepsis. many cases of pediatric sepsis are seen in children with comorbid conditions, underlying immune deficiencies, cardiac disease, oncologic disease. So I think when we think about pediatric sepsis, it's really early identification of sepsis. And you alluded to that 1 hour or 3 hour time period, which I will talk about. So I think the largest initiative in children's hospitals regarding pediatric sepsis is early identification. What I mean by that is identify them as soon as they see the first medical professional in the hospital. And who is that in most emergency departments? The emergency department triage nurse. In children's hospitals, we see thousands and thousands of febrile children. Okay, they are, quote, at risk for sepsis. But most febrile children have viruses and require minimal, if any, care. So what the sepsis pathway and protocols have evolved into is primarily early emergency department nurse triage protocols to identify the hundreds of children they may see in a week with a fever, the few that potentially are at risk for sepsis. So many of the protocols looking at pediatric sepsis in children's hospitals, and again, widely disseminated even to adult ERs who may see a minority of pediatric patients, is to identify the child with a fever in triage who has other possible confounding factors consistent with sepsis. Some of those could be high heart rate, altered mental status, poor perfusion. And then, like I alluded to, we look to see, is it an otherwise healthy 2-year-old, or does this 2-year-old have a diagnosis of leukemia and is currently on chemotherapy? So there's a few items, vital signs, a brief physical exam, and a look at any comorbid conditions. And these sepsis pathways, in a few minutes, allow the ED triage nurse to identify a child who is at high risk for sepsis. Now what happens? So you have an ED nurse saying, hey, I just triaged 100 kids with fever this week, and I am saying that this child in front of me, I have a concern for sepsis because this pathway or protocol says, and again, a lot of this is embedded in electronic health records, Ashish, that there is a concern for sepsis. What the ED triage nurse will do, and again, this varies at many children's hospitals, but I'm giving the general gestalt, that patient, after being triaged, will not go back to the waiting room. He or she will go right back to the ER proper, and they will call what's called a sepsis huddle. There's other names for that, where the nurse, the physician, the resident, the medical students will gather around as soon as that patient is brought back from the ED triage area because the nurse had a concern for sepsis, and we will take a few minutes to evaluate the patient, ask a few questions, do a quick exam, and if the sepsis huddle validates or corroborates the ED triage's concern for sepsis, all hands on deck. And that's where the clock starts working, Ashish. Okay? If we identify sepsis, we want to order the appropriate laboratory studies. We want to order the appropriate IV antibiotics and possibly order epinephrine or pressors to maintain the blood pressure. If we have a concern for sepsis based on our evaluation, our bedside evaluation, and the labs corroborate that, we like to say we have a 3-hour window to get IV antibiotics into the patient. If the patient is febrile and also has soft or low blood pressure, the infection is affecting their cardiovascular system, that by definition is called septic shock, a much more serious condition. And that's where, Ashish, we have that 1-hour window. These are very sick patients. We want to not only get the laboratory studies drawn, we want to get IV fluids into them, IV antibiotics within that one golden hour that you talk about. Now, ideally, that's how it works. Okay. And now let's flip over, Ashish, to medical legally, how that works. Okay. I think sepsis is a continuum. You could have early sepsis, which the pathway or the sepsis protocol, you hope can pick up. Okay. And let me just go back and say some comments about the sepsis pathway compared to clinical gestalt. Back in the day, Ashish, we didn't have sepsis pathways. The nurse, the doctor, we looked at a kid and said, that kid's sick. Let's get him some fluids on board. Let's do some labs. Now we have these sepsis pathways, which identify children that we should have a concern for sepsis. And believe it or not, studies have shown implementing these sepsis pathways is better than clinical gestalt, meaning they could identify these patients earlier. So I think it's a good idea for children's hospitals, any hospital taking care of children, to incorporate, and usually it's through the electronic medical record, some of the factors that are able to identify these children early so that, especially in busy ERs, Ashish, the patient doesn't sit in the waiting room for hours and hours and hours. They're identified during triage, brought back to the ER, and once a patient, whether it's a pediatric or adult patient, is brought back to the ER, I'll use the analogy of chest pain in an adult. I'm not an adult doctor, but, EKG, cardiac enzymes. With the sepsis appearing patient, or the concern for sepsis, it's all hands on deck, fluids administered, IV antibiotics administered, because we feel in that continuum of sepsis, the earlier that we can complete the evaluation, fluid resuscitate the patient, and get IV antibiotics on board to treat the infection, the better the outcome of the patient. And lastly, Ashish, specifically with sepsis, there are numerous studies showing that this whole approach to sepsis, pathway, protocolized, bundle, meaning in the electronic medical record, many systems are set up to hit one button, and it will order all appropriate labs, all appropriate fluids, and appropriate IV antibiotics with one click of the keyboard. The whole sepsis pathway approach not only reduces lengths of stay of children in the hospital admitted for sepsis, not only reduces end organ, liver, brain, kidney dysfunction, shortens that duration, but most importantly, Ashish, decreases the mortality of pediatric sepsis.
So, doctor, why? Sepsis, appendicitis, and febrile infants. Like, we ran through your podcast and we found that you have dedicated quite a few episodes to these three, and these are all high litigation areas. Now, one thing that I can think of is that because infants are involved, so emotions are running higher than usual compared to adults. But why do you think these conditions are so, they frequently end up in the courtroom?
Sure. I think let's talk about each one of those three things. Infant fever. Remember, the infant's immune system is obviously right after birth, especially if the mother's breastfeeding, we get some protection. But after that, the infant in the first 60 days of life is at highest risk, Ashish, for what we would call serious bacterial infections. And the infections we're talking about, bacteremia sepsis, in other words, a bacterial infection where a bacterial organism is in the bloodstream affecting other organs, and meningitis. Okay. In my training, Ashish, 30 plus years ago, we used to see meningitis on a daily basis. And fortunately, due to the advent of some excellent vaccines, here's a plug, Ashish, not only to the lawyers listening, but to the pediatricians, strong advocate of vaccines. And these vaccines that were developed in the 1970s, 80s, and 90s have dramatically reduced the risk of bacterial meningitis in the infant in the first 60 days of age. They have done so well, Ashish, that the pathways, if you remember 20, 30 years ago, a child between 0 and 60 days of age with a fever, they all got spinal taps. Now we are limiting the number of spinal taps to look for meningitis to pretty much the child in the first 3 or 4 weeks of age. We may do them when they're 5 or 6 weeks, depending on the initial evaluation and the laboratory test results. So I think with infant fever, you're dealing with a host, an infant whose immune system is not great. We practice protocol pathway medicine looking for that rare needle in a haystack. So Ashish, we can't do blood work and spinal taps on every single child. So we limit them based on the evidence, and the ones that I wouldn't say slip through the cracks, but the ones that develop infection and meningitis, we hope that our evaluation in the ED and our laboratory studies give us enough information that our concern for serious bacterial infection is high so that we pursue it and treat it. And some of these infections, Ashish, a child could look fine on hour one, be seen in the ER for a few hours, be sent home 6 to 8 hours later. The immune system, and I think we know this from our experience with COVID, how the immune system goes awry, and that happens with these serious infections. They look fine, the body, the host is responding to an infection, and then they fall off the cliff, and the immune system goes awry. They start exhibiting more severe signs and symptoms of infection, and that's why I think it's important in the febrile infant, if we do send them home, let's say we send a 45-day-old child home after doing evaluation, we give the families strict return to ED guidelines. But that's what happens. Medicine is an art, not a science, Ashish, and there are going to be a small number of children who fall through the cracks. Appendicitis, you alluded to, Ashish, in the podcast. I had a radiologist, a surgeon, and an ER doctor commenting as I asked them questions. And I think the big thing, I think everyone knows, many of our lawyers, appendicitis, relatively common diagnosis in the pediatric patient. Once diagnosed, a very simple procedure in the majority of cases, laparoscopic surgery to take out the appendix. Kids go home within 24 hours. I will say there is a non-operative approach. Some surgeons and families will lean toward not operating on the child with appendicitis and just putting them on IV antibiotics, a different discussion, but we do discuss it in the podcast. But I think the concern here is delay in diagnosis of appendicitis. I like to sort of joke, but it's not really a joke, that our patients do not read pediatric emergency medicine textbooks. So many of our patients with appendicitis do not present with the classic signs and symptoms. Pain in the middle of the belly that migrates to the right lower quadrant, gets worse, doesn't get better. Honestly, if I look at cases that I have reviewed medical legally of missed cases of appendicitis, they are never the classic presentation because we as clinicians are trained to recognize the signs and symptoms of classic appendicitis. But I think we need to be aware that there are some atypical presentations. And it's in these atypical presentations where the patient may be seen once, sometimes twice in the emergency department, sent home with abdominal pain, maybe from a virus or just from gas. And over time, it's really an inflamed appendix. It gets worse. And there's not a definitive timeline, but the longer that symptoms continue, 24, 48, 72 hours, there's a higher risk that the inflammation will cause rupture of the appendix, abscesses or infection within the abdomen, and then they could present much sicker, require a more in-depth surgery than just taking out the appendix, and sometimes draining the abscesses, the infection pockets in the abdomen, and that leads to a longer course of hospital stay and longer course of complications. So the goal is to identify those children early, get them in front of a surgeon, but there are many atypical cases, and even the pathways, which again, we have a pediatric appendicitis pathway, as do many other children's hospitals. We must go back, Ashish, and remember that 80-20 rule, and many patients do not fit the appendicitis pathway to a T, but you still, as a clinician, need to think about appendicitis and either perform an evaluation, or most importantly, if you're discharging those patients from the ER without performing, and let's jump right to the chase, an ultrasound of the appendix. That is the radiologic study of choice. If you're not performing it because you think they have a low suspicion of appendicitis, you must emphasize to the patient, if you can, and most importantly to the family, how appendicitis can evolve and that they need to return for care if symptoms evolve after being discharged with a vague diagnosis of generalized abdominal pain.
So, doctor, this was, very educational and informative for me, and I'm sure any attorney who listens to this will get a clear base level understanding of these issues that we keep seeing in children. Now, you've been retained in over 75 cases as the lead expert. So, walk us through your systematic approach when you first receive a case for review. Like, how do you initiate and go about it?
Sure. Thank you, Ashish, for an excellent question. And to be very honest, in a minority of cases, I get contacted by a lawyer and they say, I want any of the records. Can you do a blind interpretation? What is a blind interpretation? I think many of our lawyers know what that is, but me as a clinician, what is that? Cover your eyes? Well, sort of, yes. In other words, the lawyer would not tell me if they are the plaintiff side or the defendant side. And honestly, Ashish, I wish every lawyer practiced that way.
I agree.
Because for me to not be biased and to look at it, and again, I hope that I am unbiased when I look at these cases, whether it is the plaintiff or defendant, but I truly enjoy those cases where look at the case, give me a call when you're done looking at it and we'll discuss. I'll give them the views and the lawyer will say, let's say I'm defending the physician's care, no deviation. The lawyer says, great, we're the defense team. Fine. If I give them the same view and they say they're the plaintiff's side, well, sorry, I can't help you. Thank you for allowing me the opportunity and move on. So I think I like a blinded case first. And then I think it's rapport. I think it's rapport, just like you and I are talking, Ashish. I think you need to, I'm not going to say sell your services, but you need to justify, just like the pathways use evidence-based medicine, your opinions need to be validated, not just what you think. And I think there are so many experts out there, Ashish, who, will basically act as an echo for what the lawyer wants to hear. And if you want to use my services or if you want to be a good expert witness, I think that's the wrong way to go. Like I said, Ashish, I work for both plaintiff and defense lawyers. I want to enhance, improve the care delivered to pediatric emergency medicine doctors. If a plaintiff attorney contacts me and I don't find any deviation from care, the lawyer at times will come back. What about this? What about that? Just like a parent who asks me follow-up questions about their child, I say, ask me whatever questions you want, and maybe they will bring up something that I sort of missed in my review of the medical record. But I rarely am swayed by what they say. I do a complete thorough evaluation. They may offer things but we deposed this person and we didn't get you that deposition yet, but this is what they said. Well, I'll take that into account. But I think it's the relationship you have with the lawyers. And I try to get that. Remember, I'm an ER doc, Ashish. Within minutes of walking into a patient room in the ER, I have to get a relationship with them. I have to garner their trust because they have now given the care of their ill or injured child to me. So I have to, within minutes, gain their trust, gain their confidence. And I think I do the same thing when I'm talking with lawyers. I speak confidently. I will speak sometimes in medical terms, although explaining those, because not all medical malpractice lawyers are facile, of course, not to the clinician's degree. So we will talk sort of the talk that needs to be talked, and it's conversational. And I think that goes a long way to enhancing the physician-attorney relationship. The other thing I do that I recommend that experts do is be on time, be reachable. And I know when you talk to a lot of experts, we are clinicians first. The majority of my practice, Ashish, is caring for patients, doing education, giving lectures. A very small part of my practice and most experts is expert witness work. But I know in dealing with many lawyers over the years, they have timelines and deadlines too. And if those are not met, bad things can happen. So I think just like in any relationship, you want to be cordial. You also want to obey or align with the timeline and the deadlines that attorneys have, given the fact that we as clinicians are busy. And I think lawyers understand that. If I tell a lawyer, hey, I have a bunch of clinical responsibilities this week, fine, doc, we'll talk next week. But don't keep kicking the can down the road, because then that sticks with you. And lawyers talk among themselves. And so I feel that good relationships with counsel, them listening to you, us listening to the counsel, goes a long way building those relationships and adds to your credibility, of course, Ashish, in addition to the expertise of the medical expert, in a good working relationship.
Just to summarize the three very important points you made here. about the first one where you say it as it is and you don't try and echo what the attorney wants to hear. So last season, we had a veteran attorney who had more than 40 years of trial experience, Alvin Wolf. And he also said the same thing, that I prefer an expert who will tell me what it is, because if you tell me I don't have a case, then, like you're actually saving me hours and months, weeks and months of work and a lot of money that I would have otherwise invested in a bad case and then lost. So I think attorneys really appreciate when an expert is honest and straightforward, even though they've already spent some money by the time they've come to the expert, and they would like to hear that, yes, this is like a clear case of malpractice and this is a good case that they have in their hands. But if it's not so, they would like to hear that rather than getting their opinions and their hopes echoed back to them. So that was pretty spot on. On the second point of being available and being responsive, especially as a medical expert, I think you are ahead of 99% of other medical experts if you just pick up the phone or you reply to your emails within 24 to 48 hours. You wouldn't believe how many times we get emails from attorneys trying to contact an expert they have already retained. And they're like, oh, I'm trying to reach out to this doctor and he did a preliminary report, but now we have a deposition coming up and I'm unable to, get to them. So can you help us, get their updated contact information, or if you have their information in your database? So that's second. And the third point that you said, I again couldn't agree more to that attorneys talk. And even if an attorney is not going to probably actively go around and recommend or badmouth an expert, but when an attorney has to go and retain an expert, they usually ask around. Even though we have our own platform where attorneys come and find experts, there are other agencies that help attorneys find the right expert witnesses. But we still see a lot of word of mouth, where an attorney would come and say, okay, I'm looking to reach out to this expert witness. So they'll come to us with a specific name and they'll tell us that this expert was recommended by this attorney to me. So can you help us get in touch with them, because we don't have their contact information. So that again proves both the points about the contact information not being available, the expert not being responsive, and attorneys talking and the word of mouth still being really important. No matter how much people get internet savvy, how much AI comes into the picture, but word of mouth is still going to be the most important thing for an expert. So coming back, you mentioned using hands-on clinical practice in your evaluations, the medical evaluations that you do. So how does your active clinical work at CHOP inform your expert witness testimony? And how do you handle cases where especially multiple acceptable approaches exist, where the law calls the respectable minority rule?
Yeah, I think that's an excellent question. I think the majority of cases that I've been involved in, we call it the Swiss cheese model. In other words, they're never straightforward. So you talked about infant fever, appendicitis. Let's just use appendicitis. It's an inflamed appendix. It needs to be taken out. If you don't take it out, they're going to get sicker. It's never that easy. There are always layers, what I call the Swiss cheese models, layers of difficulty. I think it goes into, when I do write an expert report, Ashish, the last sentence in the expert report. And what is that last sentence? And I'm going to sort of paraphrase it. I say, based on my clinical experience, my education, and interpretation of evidence-based literature, these are my opinions. Okay? I don't know, Ashish, if it's a third, or 25, 50, 25, and it depends on the case. So I think it's clinical experience. Okay, I've been practicing in the pediatric ER for over 30 years. I've taken care of thousands and thousands of patients, and I think there's something to be said about that. You can absolutely use decades of clinical experience to determine what the standards of care are in our field. Education, the podcast, attending lectures, giving lectures and listening to questions that learners have. I think education is paramount, and that ties into the literature, evidence-based literature. I can't just say they deviated because I think they didn't do the right thing because there was a bad outcome. And sometimes, Ashish, lawyers want you to say that. But my opinions need to incorporate evidence-based literature into my opinions. And interpreting evidence-based literature is not always easy. Okay. There's many articles that talk about infant fever, about sepsis, and those articles need to be interpreted. We need to look at the number of patients involved in those studies to say, hey, the conclusions are valid or not valid. So take the literature, take all of my education, and take the 30 plus years of practicing in the trenches in the pediatric ER. And as I said, that's the last paragraph of my expert report. I look at all those three things, sometimes rely heavier on one than the other, but incorporate all those three things when I offer my expert opinions to the lawyers in discussing cases.
And Doctor, what's your take on, again, I keep coming back to your podcast because we actually spent a lot of time listening to the different episodes to learn about the work that you've done. And you've covered a lot. You've covered everything from pecan head trauma rules to abusive head trauma, from the ER to the courtroom, especially like the one episode that we had with Dr. Cindy Christian. So how does hosting an educational platform like the podcast, how has helped you as an expert witness? And do you think that medical podcasts and online education is changing the landscape of expert witness testimony and jury education?
Sure. Excellent question, Ashish. So let me answer the first part of that by saying the following. I think many of the podcasts have associated pathways or protocols, whether it's at CHOP or other children's hospitals. And what I have tried to do with these medical experts who come on the podcast, I have them open up the curtain to the pathway. In other words, you could be a robot and just follow the pathway, what to do, why to do it. But I've got the experts out there to say, hey, let me give you what was behind. Let me give you the hours and hours of research, the hours and hours of studies that go into putting this pathway together. And I think that's the valuable thing. In other words, we are in an AI world, Ashish, with all these pathways. You could say, why do we need clinicians anymore? Just plug them into a pathway and it'll be all automated. But we really need the understanding what comprises these pathways and protocols. And that's where the experts in the podcast that I spoke with delve into, and their expertise was invaluable in what I would call interpreting, applying these pathways to the patient at the bedside. The second part is, what's the future of podcasts? Well, Ashish, I think everyone, you, me, everyone has podcasts now. But medicine is usually always behind. So now what we are seeing is more and more medical podcasts. We're seeing more online education. My son, who's also a pediatric emergency medicine doctor, that's his niche, what they call FOAM, free online access to medical education. And if you talk, when I developed the podcast, I work with medical students, and you ready for this, Ashish? They don't open textbooks anymore. How do they learn? They learn with their phone. All the information is at their fingertips. So to make a simple answer to your question, Ashish, that's the future, okay? Textbooks are good at holding open doors if the doorstop isn't working. But today's future doctors, medical students, rarely use textbooks. They're learning from online sources. And I think what my son Josh and others that he's collaborating with are working on is assuring the quality. Ashish, you have a high quality podcast, okay? But many of these medical podcasts out there, if there is not some third party validating or affirming to the quality of the information, it's just like any social media. You know, anyone could come up with something. So what he is working on and his collaborators is all the information, the medical education that's available online, attempting to say, hey, this podcast, this website, high quality, you will learn a lot from that, as opposed to others that are not up to par.
I mean, again, I couldn't agree more, because even for me, Like I spent the last few years learning how to understand software and code and that sort of stuff. And yeah, I did not open a single textbook. So a lot of it came from platforms like Udemy and YouTube, where other people who were self-taught were probably like recording their process of learning or teaching. And even with the podcast, I think the amount of knowledge that I have gained by doing this podcast. Like, so you have one kind of podcast where you are sharing your knowledge. But here, just by talking to experts and attorneys, the amount of things that I have learned about different fields in the last year and a half by doing this podcast has been unthinkable. Like, I did not think I'll get to learn so much. So that in itself has been a great experience. And so all the best to you for your podcast and your son. I think he's again like doing a great job, because it's difficult to find credible information from people who are credible,
Sure.
and especially doctors. You are the busiest lot. So if you're finding the time to share your knowledge for free with with a population, with other doctors, I think that's a great service that is being built here. So kudos on that. Dr. Belfer, let's talk a little about evolving standards in pediatric emergency medicine and the future and litigation. And my first question here is, clinical pathways are updated regularly based on new evidence. So how do you handle cases where the standard of care may have changed between the incident date and the litigation?
Sure. An excellent question, Ashish. I think we alluded to it earlier when we look at the
Mm-hmm.
febrile infant. And those pathways and protocols, every 6 months to a year, the American Academy of Pediatrics or children's hospitals are updating, editing, making what I would call major changes to these pathways. So I think it's very important, like I said, not only to ask how old the child is, but when now obviously the medical record says it, the dates of the care. And we need to look at what, as you mentioned, Ashish, what the standard of care was, what the pathway said to do regarding that 41-day-old febrile child at the time that services were rendered. And a lot of things don't change as drastically as the infant fever pathways. And that's due to better laboratories, better interpretation of laboratories. So it is paramount when you're looking at a case to say, hey, it was 2 years ago, it was 3 years ago, and really apply the standards at the time. And I've been involved in a handful of cases where the opposing side is using literature that was published after the case occurred. And again, that evolves. So I think we need to talk apples with apples and make sure that you are using the appropriate pathways as part of the whole evaluation. Remember, not just the pathway that existed at the time that the care was rendered.
It's really interesting that you talked about medical literature, and like that's something that we would like to see more being cited in expert reports. And in fact, the previous episode, we interviewed a medical research librarian, Michael Graham, and this is his expertise, where he looks at expert reports written by experts and then see if they have cited to the current medical literature that they have cited. Is that still the standard, and has that changed? So how often do you, again, in writing your expert reports, and you're an active clinician, so you'll also draw a lot from your experience and what you're seeing in the ER. But how often would you rely on or conduct medical research to make sure that your opinion is backed by the current and the most relevant medical literature out there, and it cannot be attacked from that perspective?
Another excellent question. And let me just first answer that by saying frequently lawyers will say, have you looked at other sources, textbooks, things like that? And Ashish, you could probably answer this question better than me. You're a lawyer. Once I start stating journal articles or textbooks, the response from the lawyer is, do you consider that the standard? Okay. And then I start to sink like in quicksand. Okay. So to be very honest with you, this is my approach. I use the literature, my interpretation of literature is part of my clinical education. Okay, so I'm not referring to the article that was published in the Journal of Pediatrics 6 months ago, but I read it, and that is part of my clinical education that I use to give my opinions. Number one. When I will specifically cite the literature is in a recent case where we had a toddler who came down with a serious infection, and I was defending the case. And I tried to emphasize that the risk of a serious infection in this toddler was less than 0.5% supported by the literature. The experts on the other side were asked, what's the chance that this child had a bacterial serious infection? They said it's about 20%. That's a huge difference, Ashish. So I think in the deposition and expert report writing part of the process, I think evidence-based literature is important, will help your side. I've rarely gone to trial. I think most pediatric ER cases are mediated. But I think in trial, you have a different audience.
Yeah. In
depositions or before cases go to trial, it's medical experts battling with medical opinions, evidence-based supported. Trial, you're appealing to the jury. They may get lost in the weeds if I start referencing a Journal of Pediatrics article. But since I said very few of my cases go to trial, I rely heavily on the literature to support my opinions, yet rarely will cite a specific article. I will say that's based on my clinical education, which includes a thorough understanding of the relevant medical literature on the topic.
I think that's a good approach to have, because I mean, you're able to back it with the latest literature, but you're avoiding, and this is something that we have seen in deposition transcripts, where they would say, oh, so you cited this article by this doctor, so you agree with his theory or her theory, and do you think they are the, again, like the gold standard thing that you talked about? So yeah, that's a pitfall that one should be careful about. Is there any advice that you would give to a new pediatric emergency physician who's looking to do expert witness work? What are some of the things that they should watch out for and maybe like use to prepare themselves to do a better job as an expert?
Sure. I think before we get to that, Ashish, I don't think in the first few years of your professional career as a pediatric ER doctor, you should even consider expert witness testimony. I think you should become a seasoned clinician. I did not start this until maybe 10, 15 years into my professional career, where I thought at that stage of my career, I had a good understanding of patient care. I read numerous journals, so kept up with all the literature. And then I said, you know what? I don't like doctors who get sued. I want to defend them. And there are some bad apples. There are some doctors who deviate, leading to bad outcomes. So I said, let me offer my voice, my expertise in this expert witness field. So I think for physicians looking to enter this field, focus on your clinical day-to-day job, caring for patients. Focus on the literature. Focus on how the literature is used to create clinical pathways and protocols. Know what's behind the scenes. Don't just be a robot and say, they fit this pathway, I'm going to order this test. After you do that, maybe if you've been sued or know a colleague who's been sued, that may increase your interest in this field and you want to play a role. So I think it takes a good decade or so of practicing your profession before you should even consider entering the field.
Unfortunately, what we are seeing is sort of a movement where, expert witness work is being portrayed as, oh, it's a side gig and you can make a quick buck. And we see a lot of young medical doctors and LNCs with only a few years of experience would try and get into at least medical record reviews, and even if they're not looking to do testimony work. So do you think that's fine, or they should still spend a few more years before they try and get into doing medical record review as well?
Yeah, I'll echo the last answer, but expand upon it a little bit more. I think I see opposing experts' opinions who have that minimal degree of training, and it makes it easier for myself with extra years of training to counter that. I think just like caring for a patient, there is a skill in being an expert.
Right.
It's not just saying, hey, they did something wrong, or they did or they did what they should have done, and albeit they had a bad outcome. So I think not only becoming a good clinician, okay, but also dabbling, and the internet is a great place for that, Ashish, to sort of learn about the medical legal world. There are numerous sites, there are numerous articles talking about how some people call it the dark side of medicine, Ashish. Remember, most physicians do not like working with lawyers unless it's, as expert witness work. But there's a whole literature in that field. And just like you're educated in taking care of the child with possible appendicitis, I think there requires some degree of education, experience in doing medical expert work until you become what I would call a solid medical expert that can help lawyers on both sides of the aisle.
And what advice would you have for attorneys at firms considering building their pediatric malpractice practice? Like, what should they understand about this unique area, and what are some of the things that they can do better when they're working with an expert in this field?
Sure. I think in my decades of experience in pediatric emergency medicine, a lot of times what we do for the patient, or despite what we do for the patient gets better. And that's a good feeling. Children tend to rebound a lot quicker than adults with medical illnesses. So that helps my practice. In other words, I may not do the right thing, and guess what? The kid gets better. Thank goodness. I think some of the most important things are the following. And you alluded to it earlier, but I want to expand on it. They may get confronted with a child with a bad outcome. You name the disease. And all of a sudden, a lawyer may say, hey, bad outcome, I can get the economics experts, they come up with these life value things, and they come up with multi-million-dollar expenses that they could potentially win because it was a 2-year-old who was expected to live 80 years of life, and that's big numbers. But I think the advice to the attorneys would be the following. Reach out to a same specialty expert. So if that patient was seen by a pediatric ER doctor, find a pediatric ER doctor who's working in the same field, similar expertise, and curbside them. In my practice, Ashish, I am happy, just like I'm speaking with you, to have a 15, 20-minute discussion about the case. And usually in those 15 or 20 minutes after the discussion with the lawyer, we come up with 3 things. It's not a case. Don't even bother sending it to me. Or potentially it can be. Let me take a deeper dive into the medical record, and I'll get you an answer within a week or 2. I think that's money well spent for the reasons that you alluded to, because if they see this 2-year-old devastated child, a huge economic report that their life value is $40-50 million, and if they can recoup that in a malpractice case, wow, they see dollar signs. That's not necessarily the case. A small investment in what we would call an initial consultation, which I provide free, a deeper dive into the medical record, and if only then we feel thumbs up, we have a case in this matter, then the investment may have a greater return on investment. But don't throw all money finding 6 or 7 different experts to try to create your case. Find your one expert, same specialty, who can give you their honest opinion before you decide to invest further.
I think that's very prudent. And Doctor, you cannot have a conversation in 2025 without talking about artificial intelligence. So are there any tools that you've seen in the field of either medical record review or in your general active clinical practice of pediatric emergency medicine, where artificial intelligence has started to play a role and then something has caught your eye or impressed you?
Not necessarily artificial intelligence, so we'll get to that, but the electronic health record, Ashish. You can't fool anyone with the electronic health record. I most recently saw in a brief ER visit a 20-page audit trail. Anytime someone clicked, commented, edited, changed something in the medical record. I think that's very, very important for all practitioners to know. Big Brother is watching. This is not the era of patient paper charts. This is all EMR, and you'd be surprised that behind all the clicks and everything during a visit, there are pages and pages of what we call audit trails, which the lawyers will magnify in 50 font to show you that so-and-so canceled this order, and if this test was run, potentially it could have given you your answer. So I think the EMR, while it's starting to incorporate AI, is the beginning of AI. I think we're using AI, we're starting to talk about it in coming up with diagnoses. In other words, you input the history and the physical findings, and it lists, AI generated what the most common diagnoses are based on, of course, the information that the AI tool is fed, how they gain their intelligence. I think that is excellent for the patient. It may give you a diagnosis that you were not necessarily thinking about, which could be the correct one, because the brain of the AI, as we know, if you own NVIDIA stock or any other chips, has a lot more chips than our brain. The downside of that is I wouldn't rely 100% on that. So while it's a good tool, and I'm making a general statement, I still think there is a role for a human involved, just like we talked about interpreting a pathway, interpreting the results of an AI query. We know today some of these results are like, what are they talking about? Others are, wow, excellent, a new diagnosis or a new test I should think of. But I still think in medicine, it requires the human interpretation, the physician interpretation of the AI output. And I'm no fool. We are seeing more and more AI involvement in the medical field. I don't think it's going to ever replace my work. I think it can assist my work and help my work.
No, that's useful. I mean, I think trust but verify is probably something that can help, because we've seen attorneys being caught citing hallucinated fake cases and being sanctioned for that. We've seen fake citations have entered opinions written by judges, and then like one judge had to withdraw their whole opinion. So yeah, I mean, I think doctors would, and experts especially, need to be very, very careful at this moment if they're using any AI tools. They would save time, but yeah, you'd be better off verifying every output that you're receiving from any tool for that matter. Again, great advice. And I had one last question that I wanted to ask you. What's the best resource for an attorney to understand pediatric emergency medicine? Like if you had like, okay, go to this site or go read this book. As an attorney, if I'm seeing like, no, this is a practice that I want to build and I want to learn more about this from a medical perspective, then do you have like a couple of recommendations that you can make?
Yes, Ashish, and probably going to get on a pedestal here and go back to the TV show years ago, Who Wants to Be a Millionaire? Remember that show? And there was an option. If you, and let's put the attorney, don't have the answers to it, it was phone a friend. Yeah. Okay. I think I've talked to lawyers who tell me they listened to the podcast or they did a literature review and they are interpreting what the podcast said or what the medical literature said. Ashish, that would be like me taking first-year law classes or looking at first-year law textbooks and understanding them. Okay. I think the more important thing is to have a trusted confidant in that field who you could say, hey, Bob, this kid just earlier yesterday got a call, missed appendicitis. Can you take a look? Okay. That is a much better alternative than filling your library. Okay. And remember, we don't read textbooks anymore, but filling your inbox or filling your memory with medical journals or articles. I think phoning a friend that you have trust in, that you are able to build a rapport with, trust their opinion, because like I said, Ashish, many of these malpractice lawyers, based on the opinion of that first review of the case, are either going to say, stop, we're not going forward, or open up the wallet. We need to now invest in our case in the hopes that we will win it. So I think it goes back to what you said. Everyone's hooked up with email, artificial intelligence. I think human-to-human contact in this field is still the first step to take. and I think it's the best investment to make.
So, Dr. Belfer, thank you. Thank you so much for this very entertaining and very educational discussion. I really learned a lot. And, I had a basic idea about sepsis, about meningitis, about febrile infants. But this gave me a good insight into what issues are we seeing in courtrooms, how the science is developing. So thank you so much for that. The most important question, if somebody wants to reach out to you, what is the best way to contact you?
Sure. And Ashish, again, thank you. It was a pleasure speaking with you. I would be happy, like I said, to offer free consultations in pediatric emergency medicine cases. And best way I like to be reached is text message. And I'll give you the number. And of course, you could disseminate it, Ashish. It's 609-472-0070. I can forward you my email contacts for you to post. But again, a pleasure speaking with you for this past hour.
Thank you so much, Dr. Belfer. Have a great day.
Thank you.
If you found this podcast useful, remember to subscribe and give us a review on Spotify, Apple Podcast, YouTube, or wherever you listen to podcasts. This will help other users find this podcast and benefit from the insights shared by our guests. If you'd like to be featured as a guest on this show, please write to media@xlightum.com. See you in the next episode.